We tend to have also the most diverse biobank in the country because of where Mount Sinai is located. If you're ever familiar with New York City, I mean, we are in the Upper East Side, so you have the Upper East Side and you have Harlem and Spanish Harlem, so you get all sorts of people coming to that institution. So it's really great for us where we have a diverse group of people, but our diverse nature also have informed our implementations a lot, and maybe I might not be able to speak to that today, but hopefully sometime later. But with our patients, when we genotype for these four, we had about 77% of them carry at least one variant, and that's about 77 carried one, 27% had at least two, 5% had at least three variants in those three genes, and 1% had at least variants in 4 genes. So like I said, if we were to do it in this room for more than this, and what's important here is 2D6 is not one of the 4 that we genotyped initially. Now we have genotyped it, but initially it wasn't. But when we add 2D6, the number is about 88%. Because like I said, 2D6 is very, very polymorphic, so many people have different forms of it. And people of African ancestry, especially East African ancestry, tend to be ultra rapid metabolizers, so keep that in mind. So in our institution, we have rolled out examples that are in green. We have others. This is just a dashboard of where we are right now. We have others in the pipeline, but those in green are the ones we've done so far. Just going to quickly talk about our simvastatin rollout. So we build electronic clinical decision support tools in our electronic medical records, and we use Epic as our EHR vendor. And Epic, in Epic, we are able to build these BPAs. So this is one of the main things that I do is come up with the content for the BPAs, and also testing it out with our providers, our end users, getting feedback from them. So as we talked about simvastatin earlier, in this example, this is a patient with high myopathy risk. So the BPA will basically tell the providers what their genotype is and what the risk that's associated with that genotype. And we tell them in the box in the middle to consider a lower dose or an alternative statin, also to consider CK surveillance. And I think I'm going to show you exactly how it looks like in Epic. Okay. So this is how it looks like in Epic. So once they get this, they can click here for further information. And this usually would open up a 1-page document just for the providers to just read up on it if they've forgotten what it means to have this genotype associated with the individual. Also, they can preview the smart set. The smart set is our list of recommended medications. When they preview it, it opens up another window that brings up all the other statins that are available for them to prescribe. And once they accept the alert, it opens up this window, which copies the alert into their order entry system. So they don't have to remember what the alert said. It's there for them as a reference, and they are able to just select another medication here. They don't have to get out of that window and start the process all over again. They just continue in this process. So this is our way of basically translating our genetics through our EHR to our providers. They've been trained to use this information, and also they've been trained to ask questions if they have any questions. But we went through a lot of iterations of the BPA based on the provider's feedback, even having the recommendation in the middle as opposed to on top, which is what most institutions do. But they said that they always think of it as it's the title of the BPA, not the recommendation when it's on top. So we had to move it to the middle with some sort of coloring system there for them. And so this is some of the things that we've been doing at Sinai. Okay, so I just also wanted to quickly show you for patient education, we've created these sort of brochures. This is an example for clopidogrel. It's a trifold brochure that basically talks about what genetics is, why they should get tested, what we are doing with the information at Mount Sinai, what are the genes we are testing for, what are the medications we inform on, and that sort of thing. But we've already developed another set. This is for if that individual comes in and have been tested and we know that they're a poor metabolizer for 2C19, but they are on clopidogrel, this is a brochure to help them understand their results. And this hasn't been rolled out yet, so we're just getting to see a preview of some of the things that we're working on. And most of this work is done by my API students, so I take students on rotations and residents, and they're doing a great job, so I'm very, very proud of them. But this is some of the work that they've been putting together for our implementation effort, yeah. So in conclusion, I believe that pharmacogenomics will be an integral part of medicine. It already is at some places around the world, around the United States. I was recently in Germany just presenting on things like this, and though they don't have electronic medical records, which is an atrocity, but for a country like Germany to not have electronic medical records, it blew my mind. But they are thinking of ways that they could do this, and it's coming. You see examples in every specialty, right? Pain, oncology, infectious disease, cardiology, name it, there's one in psych, everything. So it doesn't matter which specialty that you've already specialized in. Maybe just get to know the examples that are actionable in your own specialty and you'll be okay, right? And so I think that's coming. We cannot get away from it. And in the past, it used to be oncology meds that you talked about genetics with, but that's not the case anymore. It's all over, and we need to know this as pharmacists. Implementation is gaining widespread acceptance. When I started this, I knew of maybe 7 institutions. Now there's a lot more than 20, even in the United States alone. And so there are many, many places, and even the community pharmacies that are doing this. I was on a call on Friday with Amina Bubakar. Amina has a pharmacy in North Carolina. Yeah, and she does this testing for her community pharmacy patients, and she's showing a lot of benefits. People are paying for this. Don't be. Some people think that no one is going to pay for this as a patient. There are patients that want to know this information, especially when the cost is $200, $300. Patients are paying for this. So it's a very good revenue source if you own your own place, or if you wanted to start one like that as well. And I believe that pharmacists are definitely vital to the success of this practice. We have to be part of it. If we don't, doctors are going to take the lead, and then we are going to fight them later on to get it back. And that's what happens with pharmacy, I think, all the time. It's either we're fighting with nurses to get something, or we're fighting with doctors. Now is the time for us to step up and say, this is ours, just let us do it. And we need to do this. We need to do this. Though it might not necessarily be possible in Ghana yet. I went to Ghana trying to think of ways we could do this. I went there, I was like, nah, genomics is a luxury. It's a luxury in our country. And not just Ghana, I think all across Africa, it's a luxury. And not just Africa too. There are some parts of Asia, there's some parts of South America that I think it's just a luxury, because when people just don't have access to basic healthcare, thinking about genomics is not the thing, right? And so you can think of any challenge as an opportunity, right? We use this, and we are learning from the mistakes that these first world countries are making with genomics, and so when we are ready, we will just take off without any impediments, right? And I think that's how we should think of it. It's a huge opportunity for us to make an impact in our practices. And many of these early adopter programs are led by pharmacists, or they have pharmacists in very key positions, so it can be done. I've done it by the grace of God, so I hope that everyone can try to do this at their own institutions. So these are my references, and I'll take any questions. Thank you very much.